1 minute and then we'll be good to go. I'll make that 6:30, Kai, do you?
Yep.
So, welcome everybody to the ASGBI centenary free paper series. My name's Giles Bond-Smith, consultant surgeon from Oxford, HPB in emergency surgery, and I'm joined by Kai Leong, consultant colorectal surgeon from Coventry. We're both, as well as all the moderators and everyone else out there, really looking forward to this collection of papers being presented today. And we're lucky enough to have people from as far away as Tasmania, which is the middle of the night for them. The presentations, they're going to run to 3 minutes. We are going to be quite strict on time, so it is no offence if we do cut you off halfway through your sort of talk. It's just you've gone over your 3 minutes, and then there's a couple of minutes to talk about questions. I'll be doing the introduction bit for this part, and then and my colleague Kai will be moderating the questions. So please, 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 if you're watching this via the question chat box, if you can ask questions, ask for clarification, then Kai will sort that out and moderate those questions for you. So without further ado, if we can please have Dr. Jean Flanagan, who is from Tasmania, who's produced a fantastic presentation. NELA in Australia, does the score apply internationally? Along with a colleague of hers, Aaron Rockcliffe, who we're going to hear from in a minute, under the guise of Prof. Richard Turner. Jean, thank you very much.
Thanks very much, Giles. So good morning from Australia. My name's Jean and I will be presenting NELA in Australia, does the score apply internationally? Next slide, please. For those of you unfamiliar with the National Emergency Laparotomy Audit, it's a clinical audit which commenced on the 1st of December 2012 in all of the NHS hospitals in England and Wales. From the National Emergency Laparotomy Audit data, a risk calculator was created. This is known as the NELA risk score and has been validated as a predictor of perioperative mortality in emergency laparotomy. The aim of our project was to assess whether the NELA risk tool could be applied to a Tasmanian population with our specific burden of chronic disease. From the NELA audit, Australia and New Zealand have developed the Australia and New Zealand Emergency Laparotomy Quality Improvement Project, and our hospital here in Tasmania has been contributing data prospectively to this project in accordance with its inclusion and exclusion criteria. In brief, inclusion criteria could include emergency open or laparoscopic surgery on the stomach, small or large bowel or rectal endoscopy. Eligible patients were identified from our emergency surgery unit admissions and from emergency operating lists. Our data scope was over a 14-month period from August 2018. NELA risk scores were calculated for each patient either pre-operatively or retrospectively. And the NELA risk score prediction tool gives you an estimation of the risk of death within 30 days of an emergency abdominal surgery. In the United Kingdom, this risk prediction has been shown to be more accurate than the PPOSM calculator for patients undergoing an emergency laparotomy. Next slide, please. So in terms of our results, between August 2018 and October 2019, a total of 145 patients underwent 164 operations. The median age was 68 years old. 17 patients died during their hospital admission. The most common operation performed was a peptic ulcer repair. Our NELA risk scores ranged from 0.2 to 55.1, with a median score of 8.88. There was significant association between NELA score and mortality on univariate analysis, with a p-value of less than 0.005. With ROC curve analysis, the NELA score also showed excellent discrimination for prediction of death, with an AUC value of 0.84. So next slide, please. So to conclude, despite our population differences between the United Kingdom and Tasmania, we have shown that the NELA mortality score is a valid predictor of mortality in our population. Thank you.
Well done. That was absolutely fantastic. Kai, any questions coming in?
Let me have a look. There's nothing coming through at the moment, so I think if it's okay, I will kick off with the first question while the rest of them is trying to get a bit warmed up. Jean, can you tell us a little bit about the ANZ and NELA QI data set?
I can tell you a little bit about it. Yes, so there are multiple tertiary hospitals in Australia who are contributing data to this data set, I guess. And so essentially it's, an online tool that most registrars and consultants are kind of filling in ad hoc when we have these emergency laparotomies. The inclusion criteria for us are very similar, is my understanding, to the original NELA audit inclusion criteria. So the patients have to be more than 18 years old. They have to have a Medicare number. They have to be booked to undergo an abdominal procedure where the urgency for a surgical intervention is less than 24 hours from a surgical decision. And then there are certain criteria in terms of what operations we are including. We're also including an acute abdomen, which requires emergency assessment, but may ultimately not be operated on because of patient comorbidities.
Oh, well done. Jean, you've timed that to perfection, absolute perfection. I only hope your colleague, Aaron, who's up next, can time it as well. Can I just remind people, if you're not to mute, please, so that we're just getting a little bit of interference as people, I guess, are moving around in the background. So please, can you just check that your microphone is muted? So the next speaker is, as I said, Jean's colleague, Aaron, who's also in the middle of the night down in Tasmania. NELA, more than mortality. Aaron, your time starts now.
Good morning, everyone. My name's Aaron, one of the general surgery registrars at the Royal Hobart Hospital, Tasmania, Australia. And as mentioned, I'll be presenting a paper titled NELA, More Than Mortality. Next slide, please. So as Jean previously shown, the NELA score is a previously validated predictor of perioperative mortality for abdominal surgeries. We aim to assess for an association between the NELA score and other outcomes, including length of admission, discharge to previous residence, and admission to ICU. To assess for this, we collected data prospectively as part of the NELA QI audit, which, as Jean has mentioned, is a binational audit of emergency laparotomy overseen by the Australasian College of Surgeons. And as she said, we've got extensive inclusion criteria, but to simplify it, it's patients undergoing emergency open or laparoscopic surgery involving the stomach, small bowel or esophagus, excluding those going for diagnostic laparoscopy of their own, lap chole or appendicectomy. Next slide, please. So during the 14 months that data collected, 145 patients underwent 164 operations. 51% were male and there was a median age of 68. The calculated NELA scores ranged from 0.2 to 8.88. The hospital stay was between 0 and 162 days with a median stay of 10 days. 105 or 72 of patients returned to their pre-hospital residence on discharge, and 17 or 12% of patients died during their hospital admission. So with linear regression, NELA score correlated well with the length of hospital admission, p-value of 0.005, or 0.05, sorry. And ROC analysis showed excellent discrimination for admission to ICU with an area under the curve of 0.78, and we can see the the curve on the bottom left, but it showed poor discrimination for non-return to their pre-hospital residence, and you can see the curve on the bottom right. Next slide, please. So to conclude, as well as being a good predictor of mortality, a high NELA score is also a good predictor of longer hospital admission and need for ICU, but is not predictive of the discharge location. We think this is useful, firstly for having discussion with patients and their families about their expectations of their post-operative stay, but it's also likely to be useful when allocating beds and assigning resources and guiding when the patient will be able to be discharged home from the operation date. And that's it.
Aaron, time to perfection again. You and Jean have obviously spent a lot of time narrowing this down and getting it absolutely spot on. Kai, over to you. Any questions coming in or any thoughts from yourself, sir?
Again, I think people are still a bit slow to warm up. I'm still waiting to see whether any questions. So meanwhile, I'm going to kick off because it's the second presentation. I'm going to be a little bit mean. There's a two-part question to you, Aaron. The first part is, are you surprised about the results of your study? And do you have any idea why the score that you had was not a predictor for morbidity, i.e. back to pre-hospital residents?
So the first part, probably not all that surprised with the data. Firstly, in terms of the likelihood of ICU admission, so I think it's in the recommendations that anyone with a NELA score greater than 10 should be considered for ICU. So it makes sense that people with the much higher scores, they're sicker cohort of patients, and so have a higher likelihood of needing the ICU post their operation. I guess it is surprising that these higher mortality patients aren't requiring like things like rehab or placement after their procedure. But I think it doesn't take into account that a lot of patients, even though they've got high perioperative mortality, we have a lot of patients just going simple adhesiolysis, which isn't a very morbid procedure if uncomplicated. So I think that's the reason that although they are morbid patients, they're recovering quickly from a more minor procedure and going straight home rather than to a different facility.
Just fantastic, absolutely fantastic. Thanks, Aaron. There's a lot of work gone into that, and thank you for getting up in the middle of the night, Jean, alongside as well. Thank you.
Thanks for having us.
We're gonna move straight on to Wenjing Gong, who is going to talk to us about the influence of anaesthetics on the production of hepatocyte growth factor (HGF) by fibroblasts. Wenjing, your time starts. Thank you.
Good evening, everyone. Thank you for giving me the opportunity to put my presentation. The subject of my presentation is about the influence of anesthetics on the production of hepatocyte growth factor HGF by fibroblasts. Next slide. Thanks. There is increasing evidence showing that surgery may contribute to tumor recurrence or metastasis by regulating human immune system, inflammatory system, or neuroendocrine. Anesthetics are necessary for surgery. There is a recognition that anesthetics are involved in tumor recurrence or metastasis. However, the underlying molecular mechanisms are still unclear. Tumor microenvironment play a vital role in tumor progression. Fibroblasts, as the major component in TME, also engaged in tumor recurrence or metastasis. HGF, as one of the most important cytokines derived by fibroblasts, have been proved to contribute to tumor growth, invasion, or migration. Next, please. So we hypothesis HGF derived by fibroblasts may be altered in response to anesthetics exposure and subsequently influence the surrounding cancer cells and TME, which may contribute to tumor recurrence or metastasis. Next slide, please. In our research, we selected 5 different anesthetics: RB, VB, SCC, DH, and lidocaine. MRC5 fibroblast cells were cultured with different doses anesthetics. Conventional PCR and qPCR were undertaken to quantify the HGF levels derived by fibroblasts following anesthetics exposure. Figure A and Figure B showed that SCC might inhibit HGF expression, especially at 20 and 100 microgram per ml. Figure C and Figure D showed that in VB treatment, HGF expression reduced at a concentration of 1.5 and 10 microgram per ml. Unfortunately, both groups did not reach significance. The other figures showed that RDH and lidocaine had little influence on HGF expression derived by fibroblasts. Next slide, please. Our study appears that SCC and VB might inhibit HGF production by fibroblasts. Whether the impact of anesthetics on fibroblast-derived stimuli contributes to tumor process requires further study. It provides that possible implications of anesthetics on fibroblast-derived cytokines or factors may influence tumor progression. Thank you.
Thank you, Wenjin. While waiting for others, I'm going to kick off the next question. Following the results of your study, what will be your next experiment then?
Thank you for your question. I think in the future we will co-culture cancer cells and fibroblasts. So we will collect the medium from fibroblasts following anesthetics exposure. Then cancer cells will be cultured with a conditioned medium, and recombinant HGF and MET inhibitor will be added into the medium to check whether anesthetics will influence tumor functions by regulating HGF expression derived by fibroblasts. Thank you.
Thank you.
Wenjing, that was excellent. Thank you so much. We're moving on now to Omar, who works alongside a good friend of mine, Christian Makowitz. He's going to talk to us about a closed-loop prospective audit investigating the effect of 7-day ambulatory care, something that I'm quite passionate about, on patient flow of general surgery through a university teaching hospital. Omar, the floor is yours, my friend.
Thank you very much. Good evening, everyone. My name is Omar Ismail. I'm one of the FY2 junior doctors working in Manchester. Tonight, I'd like to talk about this project investigating the effect of the 7-day ambulatory care on patient flow. Next slide, please. So a bit of background first. Our surgical assessment unit has an ambulatory care model. Now, this consists of an advanced nurse practitioner-led hot clinic. Now, this hot clinic is for patients who could be discharged from the emergency department, but they do not require immediate admission. So they can go away and come back for a blood check with or without an ultrasound. So an example would be a patient who presents with some abdominal pain, which is potentially biliary colic, but then this pain goes away. They could come back the next day or the day after and have an ultrasound scan. In our service, we've identified a number of bottlenecks. So for example, long waiting times in the emergency department, long waiting times for hot clinics, or even long waiting times for ultrasound scans. And that in particular can cause a knock-on effect, which leads to delays, which can affect the need for admission and potentially prolong inpatient length of stay. So in an upcoming Achieving Excellence in Patient Flow Week, additional funds were made available for patient flow improvement measures. We expanded our ambulatory care service to 7 days from 5 days, which included patients being streamed directly from triage to our surgical ANPs. We also increased the number of hot clinic appointments in the mornings, afternoons, and in weekends. And we also had additional dedicated ambulatory care ultrasound slots. Next slide, please. So what we did was we took a 1 week snapshot, and then we took another snapshot 2 weeks later, which was during this Achieving Excellence week. The things that we looked at were waiting times in the emergency department and ultrasound scans. We looked at the differences in admission rates, and we also looked at the bed days that were saved. Next slide, please. So as you can see, as a result of the patients who were streamed directly to SAU, we decreased the amount of time that patients spent in the emergency department. We also saw that more patients were able to be discharged by AMPs with the advice of the surgeons, or even referred to hot clinics more easily. Since there were more appointments, it was easier to get a hot clinic in close proximity, which prevented a potentially unnecessary admission. We've shown some promising data which showed that the waiting time for ultrasound scans had vastly decreased in the Achieving Excellence week, but due to our small sample size numbers, more data is needed to confirm that. And finally, looking at the average inpatient length of stays during these 2 weeks and differences in admission rates, we estimated around 70 bed days was actually saved by the trust, which is quite a significant cost saving. So in conclusion, our improved 7-day ambulatory care service, improved patient flow, prevented potentially unnecessary admissions, and also delivered care more efficiently. Thank you all very much for listening.
Thank you, Omar. Seems like it's me asking the question again, Omar. The data you showed, it's very promising. Not sure you'll be able to answer this question though. How did your consultant and his colleagues, Christian, manage to convince the radiologist to provide a 7-day ultrasound scan service?
You know, I have a lot of respect for our ultrasound colleagues. There were a lot of difficulties in promoting the service. To be truthfully, I don't know, maybe Christy Mikutrich, who was a very charismatic person, was able to convince me. But I think there was a big drive in the hospital at the time for all departments to see what they could do to improve patient flow. So I think a lot of departments were more lenient and more willing to go the extra mile to facilitate earlier discharges and prevent encourage shorter admissions.
Thank you. Giles, do we have time for another question, or is that it?
One more.
Okay, this is from Bukit. Did you look at any readmissions from patients that were originally sent home?
That's a very good question. That's not something we actually looked at. From what I remember, I don't particularly think that there were any patients that were sent home and then readmitted in either of those 2 weeks. So it would have been something that we wouldn't have been able to analyze. But perhaps if we conducted this study for a longer period of time, we could have assessed whether there were patients that were actually readmitted. But I don't remember seeing any particular patients that represented it within that week.
Omar, thank you so much. Really, really appreciate it. Best of luck. Send my regards to Christian.
Thank you.
The next person to talk is Ahmed Latif, who's going to talk to us about a great study, that meta-analysis that he's done, and I will leave it to him to describe what he's been carrying out. Ahmed, over to you.
Good evening, everyone. I don't know if you can hear me. My name is Ahmed Latif. I'm one of the surgical registrars from London, and we did quite a quick study, really comparing Hem-o-lok versus endoloop closure for a very common operation, the laparoscopic appendectomy. Next slide, please. So laparoscopic appendectomy is one of the commonest emergency operations we do in the UK, and appendiceal stump closure is quite paramount to avoiding complications. And one of the most commonly utilized techniques within the UK is endoloop ligation. However, having said that, in the US, there seems to be a growing trend to use Hem-o-loks to close the appendix stump. So the aims of our study was to conduct a systematic review and meta-analysis of all the studies out there looking at Hem-o-loks versus endoloops. Our primary outcomes were checking for intraoperative and post-operative complications, and specifically at intra-abdominal abscess formation post-operatively and wound infections. Secondary outcomes looked at the application times, the total operative duration, the hospital length of stay, and the cost of each procedure. Next slide, please. So we looked at 4 databases, namely Embase, Medline, PubMed, and the Cochrane Library. And we looked at all studies comparing appendiceal closure using endoloop versus Hem-o-lok. And we looked at our primary and secondary outcomes. And we used the random effects model for the meta-analyses. And you could see from the Prisma, we roughly analyzed 2,000 operations, just under 2,000. 992 used endoloop and 979 used Hem-o-lok. Next slide, please. So you can see there from the primary outcomes, there was no statistical difference between the two methods for intraoperative complications, postoperative complications, and looking specifically at intra-abdominal abscess, there was no difference between the two methods and no difference in wound infections. However, interestingly, looking at our secondary outcomes, the application times for Hem-o-lok were significantly shorter than endoloop, and that also decreased the overall operative duration. You can see a statistical difference between the two in favor of Hem-o-lok. The hospital length of stay didn't actually change between the two, and also more interestingly for management, cost per operation was cheaper for Hem-o-lok, so it's £27 roughly on average for Hem-o-lok compared to £71 for endoloop. Next slide, please. So in conclusion, we did not find any difference in the safety profile. So intraoperative and postoperative complications were not statistically different between the two methods. And Hem-o-lok is considered to be a safe and cheaper alternative to endoloop with a shorter application time and overall operative duration. Having said that, majority of the studies were not randomized control trials, so further RCTs are required to assess the Hem-o-lok's long-term safety profile before it can be utilized mainstream within the UK. Thank you very much.
Excellent, thank you very much. I've got one question, or two actually, it's coming now. So do you feel that we need to introduce a 10mm second port to administer your Hem-o-lok rather than a 5mm port, presumably for the endoloop? Good question, Bukit.
So there are, within the Hem-o-lok system, you can use a 5mm port. There are 5mm applicators, so you don't need to.
Okay, and then the second question from Mr. Giles Bond-Smith. What is the average follow-up time in your for the papers you looked at?
Not all the studies actually documented follow-up. Some studies, especially were done in some parts of Europe, didn't actually comment on follow-up. But on this ranged from 6 weeks, from no follow-up, 6 weeks, and up to a year in some studies. But some studies, like I mentioned, haven't actually studied or looked at follow-up at all, which is why we haven't included it.
Excellent, Ahmed. Thank you so much. Just a fantastic presentation.
Thank you.
So the next one that we're moving on to is Nadia Matias, who's going to talk to us about a closed loop audit that she's done, looking at the role of an acute abdominal pathway. Nadia, over to you. Time starts. Thank you.
Is she here?
Nadia,
is she on mute?
You're muted. You're muted, Nadia.
Can I be heard now?
Yeah.
Sorry about that.
Okay, I'll restart your time. Hang on, that's not fair. Go, go, go. Start.
Good evening, everyone. My name is Nadia Matias. I am a CT1 currently working at the Salford Royal, and today I will be presenting the results of a prospective closed-loop audit on the role of an acute abdomen pathway in obtaining CT scans for high-risk surgical patients. Acute abdomen and high-risk surgical patients account for about 10% of the surgical caseload in the UK at the moment, and it pertains to a sizable mortality requiring emergency laparotomy of about 15%. Outcomes vary with resources such as access to CT scanners overnight and in-house, out-of-hours radiologists as well. However, early CT scans have consistently proven to aid in early diagnosis and treatment of these patients and overall reduces the mortality and hospital stay. Next, please. The adult acute abdomen pathway was implemented in 2014 by collaboration between the departments of radiology and surgery. It was a risk assessment performer that would be used by the clinicians to stratify the patients according to their SIRS criteria, EWS criteria, the age, post-operative time, and the inflammatory markers. Next, please. And next. And next as well, please. The pathway was created to ensure that 100% of patients who meet the high-risk criteria for acute abdomen should have their CT reported within 4 hours of initial assessment. The key objectives to achieving this outcome was to identify acute abdomens within 1 hour of presentation and to be able to request a CT scan within 2 hours of presentation. Next, please. Next, and next, please. The methods that we chose to employ to improve this pathway was to digitalize the platform and to also educate the departments of surgery, radiology, and A&E about the platform, about the new pathway. This was achieved by collaborating with the IT team, and a new tab was installed on the intranet systems, which allowed these patients to have their CT scans booked under an acute tab. This ensured that their requests would come through as urgent. Next, please. And next. And next. And this would be displayed as such on the CRIS system, which is the national intranet system used by radiologists in the country to vet CT scans. So this would save valuable time in vetting these scans as urgent. Next, please. And next. This is the result of the original audit. The cohort of 25 patients showed a compliance of 28%, which meant that 7 patients in that entire cohort had their scans reported within 4 hours of initial assessment. Next. As you can see below in the graph, there is a considerable...
I'm going to ask you just to summarize if that's okay.
Right, okay. Next, please. And next. Oh, okay. Can we go back to the previous slide, please? So in the re-audit, there is, you can't see it over there, but it's 52%, which is a considerable improvement in the time taken to have these scans reported within 4 hours. Next slide. So in conclusion, the time taken to perform and report scans was more than half to 2.7 and 2 hours respectively, and that reduced the average time taken to report the scan to 5.5 hours, which was closer to the benchmark of 4 hours. In conclusion, discussions between surgery and radiology teams were not documented in the original audit, which should be taken into account in future audits. And the action that we would suggest would be implementation of formal national CRIS codes for urgent CT scans, improving feedback mechanisms between the surgical and the radiology teams, and continued education of surgical juniors during boot camp. And some in summary,
I'm gonna cut you there because I know that Kai may have just one quick question that we want to try and squeeze in, if that's all right, while people read that final slide. Kai.
Okay, I've got one from Anne Pullyblank. Have you managed to implement this for patients with an acute abdomen presenting on a medical admission or inpatient ward?
No, in fact, that is what we're planning to look at in the next audit. As I've mentioned in my conclusion, increasing awareness of the pathway and other specialties is key to implementing and ensuring that we get the outcomes that we're looking for. And that will be taken forward in the next succession of audits.
Thank you.
Nadia, thank you so much. Okay, sorry to cut you short there. All right, it's just in the interest of time. Next person, final person for this session is oh my
Bouquet.
Bouquet. It was always going to go there. Sorry, Bouquet. I really appreciate it. Look, Bouquet is here to talk to us about NELA cancer surgery, and is there a difference in the outcome in the older population? Bouquet, please, the floor is yours.
Thank you for hosting this evening to the panels. So my name's Bouquet, I'm a surgical registrar in London, and I'm here to present, as titled, the National Emergency Laparotomy Audit Cancer Surgery, and is there the difference? So moving on to the next slide, please. So thanks to my Australian colleagues who have already touched upon this, the National Emergency Laparotomy Audit aims to improve the delivery of care to patients undergoing emergency abdominal procedures. In this study, we concentrated on those procedures where cancer was the primary pathology. We know that the most common abdominal malignancy is colorectal, which is the 4th most common cancer in the United Kingdom. And up to a third of such patients can undergo emergency operations that can be associated with worse outcomes and significant socioeconomic inequalities. We define high-risk procedures that carry a mortality risk score of over 5%. And literature has said that increasing age of over the age of 65 can have worse clinical outcomes compared to their younger counterparts, and it can be associated with increasing frailty. So our aims were to look at whether being aged over 65 gives you a higher mortality risk score and rate, and when undergoing such NELA cancer operations compared to the younger counterparts, and does the score accurately predict deaths in both age groups? Next slide, please. Retrospective analysis of our entire database at our institution identified all cancer cases that had a histology that confirmed so. We looked at the demographics, the mortality risk score, the 60-day mortality, the bowel resection rate, and the elderly care review. And this was statistically analysed. And our results showed that we had over 700 documented NELA cases, and 119 of those were found to be histologically malignant. 80% of these patients had a bowel resection. This equates to about 15% of our annual cancer operations were undertaken as an emergency. Looking at 77% of our over 65 age group had a high risk of death versus 47% of the younger counterparts. And this was statistically significant with a p-value of 0.001. Mortality rate at 60 days in the over 65 age group was 24. And when initially predicted, the pre-op mean was also 24%. Looking at the under 65-year-old group, the predicted pre-op mean was 8%, and this was the actual mortality rate also. This was statistically significant. Kaplan-Meier is significant, demonstrating that at 30 days, 77% of our patients over 65 were alive, as opposed to 85%. 4% of our patients over 65 were seen by an elderly care specialist. Next slide, please.
If you could briefly summarise your conclusions, thanks.
So, we have a similar cancer cases emergency compared to nationally. Majority of these are bowel resections, but we know that our over 65 age group are statistically higher risk of dying. Our mortality risk score is accurate, but we don't routinely undertake elderly care reviews. So, to summarise, we know that the NELA score is a decent model for emergency cancer patients and guides the practice and the decision making. And this is far more poignant now when this was first initially submitted due to the repercussions of the COVID-19 pandemic.
Thank you, Buket. Really appreciate it. Kai, time for a very quick question.
Thank you, Buket. My question is, where do you see an elderly care specialist will have the most critical input in the elderly population? Is it before the surgery or post-operatively or even longer term?
I think with the acuity of when these patients come in, hopefully we can get them to their emergency operating quite quick from presentation to our units. Therefore, I don't think there will be the optimal time pre-operatively. I think this is most certainly in the post-operative recovery period, and certainly within the follow-up period as well.
Thank you.
Buket, thank you so much. Thank you everybody for for talking on the short papers there. Really appreciate it. We're going to push straight into the talking posters. We're going to keep our roles as we've been going along at the moment, with me introducing Kai, frantically asking questions. Please, can I just ask everybody, get involved, ask your questions via the Q&A, do it anonymously if you're shy. But we're going to kick straight off with Charlotte Boardman. Is she there, Charlotte? Yeah. Brilliant. If you could tell us about comparing the survival and mortality in the 5-year NELA with the management of guidelines from your emergency laparotomy collaborative. Fantastic. Are you muted?
Charlotte.
Yeah, Charlotte, great.
Hi, good evening. I'm a core trainee working in North London, and my project was looking at comparing the surviving patients and the patients that died post-operatively after emergency laparotomy within the year 5 of our NELA at my district general hospital. The guidelines that we used were taken from the Emergency Laparotomy Collaborative, which is a group of hospitals in the southwest of England that have put together a 6-step guideline to achieve better outcomes in patients undergoing emergency laparotomy. The aim of our project was to identify if there was any difference between the patients that survived and the patients that died in the preoperative management, to also look globally to see whether we were meeting the criteria set out by the Emergency Laparotomy Collaborative, and to identify areas where we could improve. So we collected the NELA data from a 12-month period, and we collected 99 patients, of which there was a 0.5% mortality rate. When we look at the results, we saw that the patients that died post-operatively were generally higher risk than those that survived, with 100% of the mortality patients scoring an ASA 3, whereas the mean ASA for the patients that survived was an ASA 2. And if we also look at the NELA possum score for mortality, 80% of the patients that died post-operatively were very high risk with a score of over 10%. The main difference identified was in time to the operating theatre between from the time that the decision was to operate. And we saw that the time for the patients that died post-operatively, the mean was double that of the patients that survived. However, both of these had a wide range. And then if we just look globally at our practice, in terms of consultant-led management, in terms of ITU care post-operatively and goal-directed fluid therapy, we had a very high percentage of patients receiving all of those things in line with the Emergency Laparotomy Collaborative guidelines. So in conclusion, comparing our surviving patients and the patients that died post-operatively, those that died were higher risk from both an anaesthetic and surgical point of view. The time to the operating theatre was longer for the patients that died post-operatively. However, there are a number of things to consider when looking at this, including hospital resources and how much the patient needs to be optimised pre-operation. So in conclusion, what we are planning to do is to further educate our department so that everybody is aware of the care bundle and that this is the best practice management to achieve the good standards for our laparotomy patients. And we will also follow this up with doing an audit for the next year of the NELA. Thank you.
Thank you very much, Charlotte. Seems like I'm going to be asking this one question for you. How generalizable is your data, considering there were only 5 deaths in your study cohort?
You're right. 5 deaths, when there's only 5, it means that the percentages are, seemingly a lot more significant. Ideally, what we're planning to do is retrospectively look back at the previous 4 years of the NELA, which will give us a lot higher numbers, and then also continue to prospectively look at sort of year 6 and onwards to get a better picture. But this was sort of the first step in looking into it.
Well done. Thank you.
Thank you so much, Charlotte. I wish you well. All right. Thank you. So next up is Nicola Reeves. Hopefully Nicola's ready. She's going to be talking to us about defining what are we talking? Defining the denominator, emergency laparotomy and frailty study 2. Nicola, are you there?
Yes, I am. Hi, good evening. I'm Nicola Reeves. I'm one of the research registrars based down in Cardiff. Now, we've been working together with the Welsh Barbers Collaborative, with the Scottish Surgical Collaborative, and also NELA and OPSOC to bring you what we call ELF2, so defining the denominator. Now, many of you are familiar with ELF1. This was a really big study that was carried out a few years ago that demonstrated that frailty of patients was a better prognostic than the NELA score. And actually, we should be assessing whether patients are too frail or their frailty status before taking them and undertaking the big operation, and talking to them and providing them with better informed consent about what may happen to them in their 30 days and 90 days after their operation. Now, with all of the NELA data and with the data from ELF1 and from most hospitals, we're getting much more familiar with our outcomes for the emergency laparotomy patients. However, I still think there's a group of patients that are largely unknown, and this unknown entity is what we've determined as the no-lap patients. So those patients that come in on the emergency take, that have a pathology that require an emergency laparotomy, but for multiple reasons are deemed not suitable or eligible for an emergency laparotomy. And what ELF2 is going to be looking at is how do these outcomes differ in patients eligible but not undergoing an ELAP or emergency laparotomy. That's our primary outcome, and the secondary outcomes will be looking at how this group is defined. So what were the reasons for decisions to not operate, and that comes from multiple factors, including patient factors, surgical factors, ITU, anaesthetics, and then also looking at different prognostic scores, surgical diagnosis, and what happens to these patients at 30 days. Many people think that when you don't do a laparotomy, that these patients are then palliated, but often some of these patient groups do survive. It's going to be a multi-centre study, and we were hoping to have started it back in March, and this was going to be the first presentation of our preliminary results. However, due to the COVID crisis, we have decided not to do that and to hold off until the COVID incidence has decreased. And we're hoping to start this in October and prospectively recruit 700 patients with a 90-day follow-up. We've got many hospitals already interested and signed up, but any hospitals that wish to come on board, please feel free to email us and have a look out for us on Twitter. As a side point, we're also going to add COVID as a sort of caveat onto this study, so to see whether the influence of COVID or COVID influences the decision whether to operate or not. So even if there is another surge of COVID, then we're going to be prepared to go. So thank you, and I'm open to any questions.
Thank you. Giles and I have the same question. If we're interested, how do we enroll for this study?
So we have an email address, which unfortunately is not on the slide, which I do apologise for, but many people do use Twitter. So if you just have a look for ELF on Twitter, then you can access us through that. We have been a bit quiet on the email returning at the moment, but we will be back on it as of this month, hoping to get it up and rolling in October.
Thank you very much.
Nicola, excellent, and I really wish you well. Strong work, it's brilliant. Thank you.
Thanks.
Giles, you're on mute.
Thank you. Sorry, I muted myself there. Saeed, talking about group and safe screening prior to emergency lap appendixes. This is going to be good. From UCH, brilliant.
Hi, I just unmuted myself. Good evening, everyone. My name is Saeed, and I'm CT1 in surgery at currently the Southampton General Hospital. I did this audit when I worked at the UCLH last year, and very quickly, the standard or the practice at the UCLH was to, I'm not sure if I can zoom into the slide. So everyone can see.
No, you can't zoom in.
So yeah, sorry for that. So the standard at the UCLH was that every patient going to have laparoscopic surgery for right iliac fossa pain, including diagnostic laparoscopies and laparoscopic appendicectomy, need to get 2 group and safe samples sent to the laboratory before being taken to theatre. So we wanted, when we did this audit, we wanted to examine the necessity and cost effectiveness of this practice by looking at the post-operative perioperative transfuse rates for these patients. So the first study, which is the major one that we did, we collected the data retrospectively, covering a 2-year period extending from the 1st of January 2017 to the end of December 2018, so a 2-year period. And the number of patients was in this sample around 451 patients. And we looked mainly at whether group and safe samples were sent for each one of these patients, and the number of samples sent, and transfusion rates, as well as if there were any rejection reasons by the laboratory. So we found out that 930 samples were sent for these patients. So the majority of patients, around 300, had 2 samples sent before going to theatre, and smaller groups of patients had either 1, 2, 1, 3, or 4 samples sent. There's a number of samples that was rejected for different reasons, around 144 samples rejected for different reasons, and the transfusion rate was only 0.4, which accounted for 2 patients having been transfused for different reasons, completely irrelevant to the laparoscopic appendicectomy. So we implemented some changes, made some recommendations, and repeated the audit 6 months later, covering a smaller period of 4 months, extending from May 2019 to the end of August 2019. So the sample included only 63 patients. And the number of samples sent we found for these patients were only 53.
So your conclusions.
Yeah, so the conclusion that the hospital managed to omit this practice, and it proved that it is clinically indicated and safe for patients to not have group and safe samples before being taken to theatre for diagnostic laparoscopy or laparoscopic appendicectomy. Thank you.
Well done, Said. Kai.
Thank you. I've got a question, Said, not from me, but from the panelists. What do you do if the blood bank is off-site?
So we use O-negative blood mainly, and we also try to focus on operative measures such as conversion to open surgery and control the bleeding, or as I said, use of O-negative blood.
Okay, excellent. Thanks, I appreciate it. Okay, good luck, my friend.
Thank you.
So we're cooking on gas. It's now Alistair Hastings, women of childbearing age presenting with lower abdominal pain. How useful is an emergency pelvic ultrasound scan?
Okay.
Good topic, good topic.
Hello, my name's Alistair Hastings, an RFY2 from Forth Valley Royal Hospital in the west of Scotland. Today I'm going to talk to you about the diagnostic value of emergency pelvic ultrasound scan in females of reproductive age presenting with lower abdominal pain. An important topic because lower abdominal pain is a common presenting complaint and one which we use a significant amount of radiological resources for. In terms of our methods, we identified patients from our handover documents over a 4-month period of emergency admissions and selected patients using the following inclusion and exclusion criteria, which you can see in Table 1. We then conducted retrospective review of the clinical portal and PACS to identify their admission blood test results, the results of the pelvic ultrasound scan, and operation notes if applicable. Moving on to results, there were 79 patients included in the final analysis with an average age of 26. Looking at the length of stay for the 79 patients, they had a combined length of stay of 152 days with an average of 1.9. When we looked at the subgroup of 27 patients in whom the white cell count was less than 10 and CRP was less than 5 on admission, this group had a combined length of stay of 37 days with an average of 1.4. Looking at the results of the pelvic ultrasound scans across all participants in Figure 1, 64.5% were reported as normal, 12.7% showed single ovarian cysts, 13.9% showed other gynecological pathology, and there are a number of other diagnoses in small numbers which can be seen in Figure 1, including appendicitis. Looking at the subgroup specifically with white cell count less than 10 and CRP less than 5 in Figure 2, 81.5% of these ultrasound scans were normal or had incidental findings only, and 7.4% showed single ovarian cysts. The same amount showed polycystic ovaries, and 3.7% showed a hydrosalpinx. In terms of the management of this particular subgroup, 63% of the patients were given analgesia and discharged, 7.4% received oral antibiotics and were referred to gynecology. 7.4% were referred to gynecology, and the same number, 7.4%, underwent laparoscopy. It should be noted though that the 2 patients, the 7.4% that did have laparoscopy had normal pelvic ultrasound scans, and it was not the ultrasound scan which led to that management. So we concluded that in women of childbearing age presenting with lower abdominal pain with normal inflammatory markers, emergency pelvic ultrasound scan is unlikely to show any pathology requiring surgical intervention, therefore may be of limited value in this context. Early discharge and referral for outpatient investigation or review, and perhaps in hot clinic, may be more appropriate. And
Alistair, that's fantastic. I'm just gonna end it there. Kai, have you got any quick questions for
Yep.
Alistair?
Right, a quick one. Can I ask you, the patients with a white cell count of less than 10 and the CRP of less than 5, did they have the ultrasound scan as an inpatient or outpatient?
Good question. Yeah, so most of them had it as an inpatient. We do have a hot clinic service at our hospital, but certainly in our study, most of the patients did stay in hospital for that. And if we were able to get their pain under control and discharge them with outpatient follow-up, we could have potentially saved 37 nights in a hospital bed, which is a significant cost saving, obviously.
Thanks, Alistair. That is brilliant. Thank you. So to our final poster is Vaish, talking about somatic symptom disorder and abdominal pain.
Hello everyone, thanks for having me. I'm a surgical HMO. I'm currently working at Melbourne in Australia, but I'll be talking about a study that we're doing at the John Hunter Hospital in New South Wales. So a commonly encountered presentation in the acute general surgical setting is undifferentiable abdominal pain, which is often a difficult and frustrating diagnosis for both the patient and the clinician. There is certainly a link between mind and body, and by that I mean we are aware that psychological distress can manifest itself as physical symptoms. Somatic symptom disorder, or SSD, is a DSM-5 diagnosis wherein patients experience a somatic symptoms such as nausea, headache, abdominal pain, or GI disturbance, but continue to ruminate or have intrusive, distressing psychological thoughts towards a symptom that are out of proportion to the severity of that symptom, often prompting them to seek medical treatment. The absence of a diagnosis or a scientific explanation for their symptom can lead to further anxiety and worry regarding the presence of this symptom, and this can be debilitating for the patient. Unfortunately, it's difficult to establish this as a diagnosis, particularly amongst acute general surgical patients who need to have surgical emergencies ruled out prior to making a diagnosis like this. Often this leads to imaging, ultrasound, CT, overprescription of analgesia, particularly opiate analgesia, and delays where patients may remain in a hospital bed whilst the diagnosis is still being made. Many of these patients re-present with similar symptoms and have repeat radiological studies done and tests done in a bid to find the cause for their symptoms. Our study recruited patients who were admitted under the acute general surgical unit at a tertiary teaching hospital. Willing and consenting patients would complete a survey that used 3 validated questionnaires which screened them for somatic symptom disorder, generalized anxiety disorder, and depression. The surveys also collected information on any comorbid psychiatric illnesses, any medications they may have been using, the number of times they had sought assistance for their symptoms in the last 12 months. We also noted their white cell count and CRP throughout admission, as well as their daily average morphine milligram equivalent, so how much opiate medication they were having to use each day as an inpatient, and the average of that, and any radiological studies they may have had done, any surgeries done, and the outcomes of these. So we found that the prevalence of somatic symptom disorder in the acute general surgical unit was 16%, which is consistent with population prevalence studies. Patients who screened positive for somatic symptom disorder were prescribed twice as much opiate or twice as much of the morphine milligram equivalent as those without SSD. They also had 2.5 times the rate of having a comorbid psychiatric condition such as generalized anxiety disorder, depression, borderline personality disorder, and more. And they stayed in hospital for an average of 2 days more than their non-SSD counterparts. So in conclusion, somatic symptom disorder is something that can drive patients to seek medical care repeatedly for their symptoms, for which they may have intrusive or distressing thoughts that are out of proportion to the severity of their symptom. And this includes presentation to an acute general surgical unit. The prevalence of somatic symptom disorder in the acute surgical unit is reflects similar to the population studies, which is about 16%. And I guess for us, it means looking out for the undifferentiable abdominal pain on these units. And of course, you must treat everything as you usually would and rule out any surgical emergencies. But if you think that this may be a contributory factor, there is benefit in referring the patient for outpatient psychology, psychiatry, or general practice input for regular visits.
That is brilliant. Thank you so much. I appreciate it's the middle of the night where you are. And sterling work to stay until the end and give us something which is actually really useful and we all see on a regular basis. Kai, I'm going to let you have just one question there, if you can.
Thank you, Vash. Good morning. I just wanted to finish it off because that was my question really. What would be your advice about managing patients with SSD in the secondary care? Go on then, finish it.
It's a very contentious issue. I think we need to do more research on something like this, but essentially dualizing mind and body has not been found to be helpful for them. So what they need is someone to regularly reassure them, take them seriously, talk them through whatever symptoms they're having, and just connect with them and reassure them that, you know, that these symptoms aren't leading to anything life-threatening, even though we don't know what is causing them. And also, the mainstay of treatment is cognitive behavioural therapy, and to be linked in with a trusted physician who can reassure them.
Thank you.
Yeah.
Great. I'm going to say a big thank you. I'd like to thank all our speakers tonight. They've been absolutely on point. If we look at the final slide, you can go and have a look at all the posters there. Please, can I remind you to tune in again next Tuesday, the 11th of August. I'd really like to say a big thank you to Kai for putting a sterling effort in monitoring all the questions and asking the questions there. Also, a big thank you to all the people viewing and asking questions alongside as well. Love to be able to do more, but time pressures keep us from just limiting the amount of questions we can ask. Big thank you to the ASGBI. We really do enjoy these sessions, and thank you for all the effort that the speakers have put in. Just fantastic program. Kai?
Thank you very much, everyone. I hope you found it as interesting and useful as I did.
Perfect. Take care, everybody. Hey, Kai.